happy to talk to Jody Tavalieri today. He works at Henry Ford. It's now Henry Ford St. John in Michigan, and it's one of the first centers in the country, I think, to offer this procedure, and
Correct.
one of the biggest now in Michigan too. We're going talking about HIPEC versus PIPAC procedures. It's their hypothermic intraperitoneal chemotherapy. It's a groundbreaking treatment for people who have, I think, advanced stages of cancer, correct?
Yes, generally people with peritoneal carcinomatosis. So people who've had colon cancer, ovarian cancer, gastric, appendiceal, one or maybe there's another one, but basically it's they have disease in their belly that is spread to their organs, peritoneum, and then they so the intravenous chemo doesn't necessarily reach them the same way as both HIPEC and PIPAC. The HIPEC is hyperthermic intraperitoneal chemotherapy, and PIPAC is pressurized aerosolized chemotherapy,
Hmm.
pressurized intra-abdominal chemotherapy. And the difference is both of them are actually making contact with the cells in the organ, the tissues in the abdomen on the different organs and penetrating them. With a HIPEC, they're heated chemicals, and with a PIPAC, it's just aerosolized and under pressure. And there's indications why they're separate, a HIPEC and a PIPAC. I don't know. I'll let you ask me whatever.
Yeah, I was kind of reading like if somebody can't actually, if they're not optimized to have a high PEC because it's a longer, more like invasive procedure or more strenuous on them, then they opt for the PIPEC.
That's true. It's the HIPEC can be curative, and the PIPAC, or to say it easier, PPAC, just to differentiate them. Typically, the HIPEC can be curative. So if you have only a limited amount of peritoneal carcinomatosis, the surgeon can go in and look and do a cytoreductive surgery, remove as much cancer tissue that they can find, and then they close the belly and circulate this heated chemotherapy. But
Hmm.
it's typically a 6 to 12 hour surgery, sometimes 20-hour surgery. So you need a certain amount of stamina to be able to get through that. There also is something, most of the surgeons, they do this thing called a peritoneal carcinomatosis index, where what they do is they count how many quadrants and how many organs have carcinomatosis on them, have tumors in those regions and on those organs, and then they make a decision if resection would be beneficial for them. I'm sorry if you hear any stuff in the background, but if you have uh like typically they do this thing, the surgeon will do this thing where he gives everything a number, and so peritoneal carcinomatosis index of like 20 and below, he or she would often go ahead and do the resection and the HIPEC. If it's higher than that, it might not benefit the patient. The research doesn't show that it benefits the patient. So they do this thing called a pressurized intra-abdominal or chemotherapy, aerosolized chemotherapy. And so when they do that, you don't liquid. There's only 2 ports, but it has been shown efficacy in reducing ascites, reducing bowel symptoms, and giving some longevity also for those,
Okay.
even though they might not be able to take the HIPEC. And sometimes with the PIPAC or PPAC, it's a stepping stone to a HIPEC. If you can get
It,
enough reduction in disease, you got it.
mm, yeah, I
You can,
read that it's like a bridge to to the higher surgery.
you got it.
Yeah. So is it just for like, well, I would imagine too that they're pretty late stage when these diseases are found anyway, but is it only for diseases that are metastasized already?
Yes, that's
Mm,
correct. So
okay.
there are times when we go in. I'm sorry, I say he, but he or she, the surgeon, says they go in and they look and they say, I don't really see any disease. I'm not going to do this.
Mm,
It's not often, because usually we have some data that says that there's disease there, but it has happened. Or sometimes when there's such limited disease and there's not abundant obvious disease, we've done a laparoscopic HIPEC where he doesn't open the full belly. He just puts the ports in and circulates heated liquid chemotherapy. But those, again, that's more with That's still younger, healthier people. And
Yeah.
not necessarily younger. Sometimes we're doing people they're in their 60s and 70s. It's young, but
Yeah. But they're optimized. They're
right.
been healthier. Yeah. So talk about anesthesia for that. You can't be in the room
Well,
during the chemo.
for the PIPAC, we are not. So for the PIPAC typical patients are anywhere from their 30s to 70s, and it's a relatively short procedure. In its simplicity, I would just say that it's basically a laparoscopy with two ports. The things that complicate it is the aerosolized chemotherapy, because we don't want any staff in the room during the administration of that. We take several precautions to make sure that it's safe, but still we remove everyone from the room during that. And so we have remote monitoring outside of the room. With our modern operating rooms, the way they're set up, the airflow is from the ceiling to the vents lower than the ceiling. We put multiple covers on the patient, plastic sheeting on the patient. We cover the administration device. It's administered under pressure. We have several safety mechanisms that even if there was a release, it would probably be contained. Anyway, so that was kind of when our surgeon at our place brought that up. Uh, this guy named Richard Berry, we all were like, "Oh, that sounds exciting, but not really," because we could be exposed to chemotherapy in our eyes and our lungs, and stuff. But after research and looking at centers, researchers were doing this in Europe before it was kind of developed in France. And then now we are one of 6 centers in the country that does it. We're the only place in Michigan that does it.
Mhm.
Um, for in its essence, a patient comes into the room, and we either use perfusion to administer the chemotherapy under this high pressure device,
Hmm.
or some places use an interventional radiology nurse to administer it. Some places use them. We have two ports, for one for a camera and one for the scope. We go to sleep. I encourage people, some of this is anecdotal and some of it is research. Basically, I would say the thing is when you leave the room, you want that patient's ventilatory status and heart rate and blood pressure to be the same, stable. You don't want them, you don't want to be having to treat their blood pressure from outside the room all the time, or
Right.
treating heart rate from outside. And you don't want to, at our place, our anesthesia machine, in order for us, which most places, to make changes like to your vent, you have to go into the room to make them. So you want to be able to, you want to have them optimized before you leave the room for their vital signs and for their ventilation. What I encourage is the patient will come in the room. We go to sleep without narcotics. We stay without narcotics.
Hmm.
It's not a painful procedure. There's
Right.
two 1-inch procedures. We get the patient to a good place with ventilation and with their heart rate and blood pressure. We paralyze them significantly because, again, we're outside the room. We don't want them coughing and bucking on the ventilator while we're outside of the room. Something happened. And then we start a second IV. So we have two IVs. So we leave the room. We have emergency drugs outside. We have our monitors outside that you may
Mhm.
have seen a picture
Yep.
in that one pamphlet. But most places don't have a monitoring system like that do that. Most places have a slit in the door, or they're looking like in a window at the.
Like, yeah, for like MRI. Sometimes I'll draw a big line out to my out to the MRI room.
You got it. That's
Yeah.
exactly it. Yeah.
Okay.
So, but we were able, fortunately, to set up a system where we have monitors, and we have our monitors out there. We have two IVs out there. We have resuscitative equipment out there. And
Mhm.
then we have the ability to gown and glove and protect ourselves and go in rapidly if we have to. I've had to one time, there was a problem. We've been doing this now a year. We started
Mhm.
last January. And one time I had a patient who had a problem and an allergic reaction. And so
Oh
I had
gosh.
to go in and manage that. But I was happy because we practiced these things. So I was able to get in that room in about 30 seconds. I was gowned and gloved, and
Mhm.
I was in the room. So that was cool. Our perfusionist who runs the chemo delivery device, also, he's had to go in there twice, and he was able to go in there like just rapidly. So there's a lot of prep with this as far as safety, but it works out. And we had dry runs with this and stuff like that. But anesthetically, sorry to your question, that's about it. These patients are typically have more nausea and vomiting. We usually give a couple doses of Zofran instead of our typical 4. We usually give one at the beginning and one at one at the end because we paralyze them significantly. We use Sugamadex to
I
reverse
can.
and they don't lose blood. The fluids are nominal. We do usually replace like 10 milliequivalents, 20 milliequivalents of potassium and 2 grams of magnesium. The chemo can chelate some of the potassium and magnesium out of the blood. So we've gotten in the habit of replacing them, but we haven't had any problems. That's what we did.
About how long are you out of the room?
Great question. We we go through a checklist. Everybody is on the same page, and then we go outside of the room. We bring our IVs, our drugs, um, and things like that. And we get out of the room. We check our IVs. IVs are running, monitors are working, have our stuff. I'm okay with the ventilation. I'm okay with the blood pressure. And we go through a checklist once again. And then we're the ones that say to perfusion or to whoever's going to activate the delivery,
then-
go ahead. And the actual chemo delivery only takes about 5 minutes. So there takes about 5 minutes for the chemo to go in. And then there's maybe another 2 minutes of clearing the line of the chemo that's in there so the patient gets the full calculated dose of chemo. And then we sit for 30 minutes. So there's why I want them to be stable and not and have a MACA gas on and be very paralyzed because we're sitting out there for 30 minutes and that
Yeah.
won't be stable during that time. So it's a total of about 35 to 40 minutes that we're out of the room. And then the surgeon and the scrub, gown and glove, they go back in the room. They look at our sheeting over the patient, at the delivery device that's covered with plastic, and they make sure there's no moisture in there. And then they say, and they wave at us, and we all go,
That's how you determine it's okay to come back in.
yes.
Yeah.
One other caveat with that is that, like, when they're done, again, there's 2 ports, but they us and this other place where we went to see how they did, and Stony Brook Hospital in Manhattan. They both of us pre-close. So when we go back in, when they're closing their ports, it's only a few minutes. So it's almost like we're going back in, turning off the gas, reversing them, breaking down our IVs because I didn't say that we put like 4 or 5 extensions on the outside, as you know, you've done with MRI
Yeah.
maybe.
Yeah.
So we break all that stuff down, give our reversal and our antiemetics, and usually we'll give them some Toradol, and then we see if they need some analgesia when they wake up. Then we'll give them some. Usually they don't. Usually comfortable because they also do a little field block. They put some local in the incisions there.
Are they closing the ports then under the plastic? Because once they pull those out, don't they fear it comes out?
Great question. When the surgeon and the scrub go back in, they evacuate the abdomen 3 times. They use this giant evacuation device and they evacuate, fill the abdomen, evacuate, fill the abdomen, evacuate, fill the abdomen, evacuate. And there is I've looked at several workplace studies. I don't want to say OSHA. I don't remember if that was the governing body, but several studies, and there's no detectable chemo in the anesthesia area above the table. There's no detectable chemo in the room.
Yeah.
Yeah.
What chemotherapy? Sorry, what agent are they using?
Okay, so usually the most popular one that has been used in the past has been a platinum agent. This one that they used is oxaliplatin, which is similar to cisplatin, kind of renal toxic, but
Yeah.
um, it's a it's a different way that we're using it. When we use cisplatin in the HIPECs, we do give it with sodium thiosulfate to any cisplatin that's absorbed. But with the oxaliplatin, we don't. I think it's partially because of the time and there's not as much absorption. There hasn't been any problems with people having acute kidney injuries from it administered this way. But so mostly they're using these platinum agents. Oxaliplatin is the one typically that they use. But the funny thing was our very first patient had an allergy to oxaliplatin. So we had to use something else. And so we used a drug that we use with the HIPECs usually called mitomycin or mutamycin.
Okay.
And now this is completely anecdotal, but it seems like the aerosolation is a little bit different of the mitomycin than the oxaliplatin. And it's possible that there might be more coverage or different surface area coverage. And so there is now a study going on comparing the two.
Okay. So was it your very first patient that had the allergic reaction?
No,
Oh, okay.
it was another one. he did end up having some angioedema and other things that pointed to that. And so he, it was an allergic reaction, but he did well with it. You know, he
That's
got,
good.
yeah. So we jumped
That's
on, but it was
so
funny because we're
Mhm.
outside and we're treating it like a normal. We're thinking something's wrong, and then we're treating it with phenylephrine and ephedrine, and it's not working. And as soon as I gave some epi, boom, he's like
Yeah.
snappy, coming around. It was something. So thank you.
Wh- are you using Zemuron, or do you have to use a longer acting?
We just usually use Zemiron. Yeah, it's just super predictable, but the typical situation. So when when you go in, the time between induction and leaving the room is probably about 40 minutes.
Hmm.
So that's a little bit of time to get them kind of where you want them to be, but it's kind of nice because the rocuronium or Zemiron is pretty predictable. So we'll usually go to sleep with that. Maybe they have a twitch, come back. Maybe they are somewhat recovered, 10% recovered or something. But then we just usually give, you know, normally if somebody has one twitch, you might give them, another 10 milligrams for a half an hour of muscle relaxation, but we'll just give them, we go above that. We'll give them 30 or 40 milligrams. And usually with that, by the time we come back in, they have a post-tetanic twitch. And if they don't, we just use more,
Sugammadex.
Sugamidex.
Yeah,
Yeah.
yeah. About how many do you think you do a month?
Well, probably, I would say we're probably averaging around like this month. This we're gonna have 8 of the PIPACs, but we're typically 4. I would say 4 to 8 a month. But these happens is these patients come back maybe for 3, 4, 5 of these PIPAC procedures. Yeah, if we and we've seen significant regression of disease with them.
Mhm.
It's really something. Some of them have some other problems, the normal problems people get with cancer, with infection and thrombosis and different things like that.
Yeah.
But these patients typically will come back, and we've seen because they do the scope, and the first thing we're all looking to see is what does the belly look like. And
Mhm.
we've seen some that our surgeon has even wanted to offer them the HIPEC procedure, but they're kind of hesitant because I got these 2 ports here and it's not so bad to recover from versus a xiphoid to pubis symphysis incision.
Yeah.
So they're kind of hesitant with that. But
That's
yeah,
10 to 15 hour surgery or whatever you said it was.
yeah,
That's incredibly stressful to go through for them.
it is,
That
but they do really well.
they do.
I can't believe how well they do. It's
That's good.
because you see them afterwards and it's like, this is pretty amazing. They heal well and they do well. Most of them. Do. And
Well, that's good.
yeah. Yeah.
Well, I
But
appreciate. Go ahead.
thank you. But it's kind of, it's new and it's growing and it's changing, but it's kind of new and it's evolving and it's kind of cool for us to be involved in.
Yeah, it's making the news. You guys are leading the way, especially in Michigan. So it's pretty cool to talk about it. And
Sure.
it's one thing to step out of the room for a minute, but to be out of the room and watching them and having to treat them and the complications if you do go in there, it's a lot to consider. Mm.
Well, thank you.
Awesome. Thank you. Have a great day.